All right, let's dive right in. Today we're stepping inside the exam room to roleplay our way through a classic general surgery viva station, the anterior neck swelling. We're going to simulate this just like it's the SCFHS consultant's exam. So if that's what you're prepping for, you've come to the right place. Let's get started. A scenario like this is way more than just a test of your knowledge. It's really designed to see how you think on your feet under pressure, which is, of course, a key skill for any consultant. The SCFHS exam, and frankly most exams like it, is all about showing you have a logical, confident approach. It's about proving you're ready for that responsibility. So, here's our game plan. We're going to follow the exact path of a real clinical station. It'll kick off with the opening scenario, then we'll walk through how a top-notch candidate would tackle the history and exam. After that, we'll get into the diagnosis, plan the investigations, map out the management, and even talk about long-term care. And at the end, we'll wrap it all up with the key takeaways for success. Okay, picture this. The exam room doors close. You take a seat across from the examiners. They look up, make some brief eye contact, glance at their notes, and then the station begins. From this point on, I'm going to be playing both the examiner and the candidate to really show you how this whole thing flows. And there it is, the classic opener. It's short, it's to the point, and it gives you just enough to start building your mental framework. Right now, your brain should be racing with possibilities, but your first response, well, that needs to be all about your process. Let's see how our candidate should handle this. This is your first real chance to impress. Don't, whatever you do, jump straight to a diagnosis. You have to show the examiner your process. Remember, they're not just listening for facts, they're watching how you think. A structured approach here is absolutely everything. And there's the first prompt. See, they're not asking for the answer yet. They're asking for your method. The only correct way to start is from the very beginning, a thorough history, then a focused physical exam. Okay, so as the candidate, I'd say something like, I would begin by taking a detailed history, and then you just lay out your structure. I'll start with the presenting complaint. When did it start? How long has it been there? Has it changed in size? Then I'd ask specifically about any obstructive symptoms. Trouble swallowing, breathing, any voice changes. Next, I'll screen for symptoms of thyroid dysfunction, both hyper and hypothyroidism. And finally, I'll ask about any past exposure to neck radiation, and, this is crucial, any family history of thyroid or other endocrine cancers. So the examiner gives you the findings. Now notice how most of this is negative. No pain, no trouble breathing. But then you get to that last point. A father who died of thyroid cancer. That is a massive red flag. That one detail changes the whole picture and should rocket malignancy right to the top of your differential diagnosis list. So the examiner will likely say, what will you do next? As the candidate, you just smoothly transition. After taking a full history, I would proceed to the physical examination. You start with the basics, right? Vitals, general appearance. Then you zone in on the neck. You'd say, I'll make sure to position the patient properly and expose the neck. I'll inspect the mass, then ask her to swallow to see if it moves, a classic sign of a thyroid mass. I'll also have her stick her tongue out, just to rule out a thyroglossal duct cyst. Then I'll palpate the mass from the front and the back, checking its size, consistency, and mobility. And of course, a key part of the exam is checking all the cervical lymph nodes. And finally, I'll look for any eye signs of thyroid disease. And here are the findings from the exam. Okay, the mass moves with swallowing, which pretty much confirms it's from the thyroid. But the most important finding here is its hard consistency. A hard nodule, especially when you have that family history of thyroid cancer, is incredibly suspicious for malignancy. The picture is getting clearer and clearer. Okay, so you've collected all your data from the history and the exam. Those red flags are waving. Now it's time to put all the pieces together and come up with a plan. This is where you synthesize all that information and really show off your diagnostic skills. Now the examiner wants you to commit. Based on everything you know so far, a 35-year-old woman, that really strong family history, and a hard thyroid nodule on exam, there's really only one primary diagnosis you should be offering up. My provisional diagnosis is thyroid malignancy. This shows you can prioritize a serious condition based on the clinical evidence. It's the right answer, and saying it with conviction is what gets you the points. The examiner is going to follow up with, so how are you going to manage this patient? As the candidate, you need to present a logical, step-by-step plan. My management will start with investigations, which I'll break down into labs, imaging, and tissue diagnosis. For labs, I'll get a thyroid function test to see what the gland is doing, plus some baseline liver and renal function tests. For imaging, the gold standard is a neck ultrasound. And for the tissue diagnosis, the crucial next step is an ultrasound-guided fine needle aspiration of that nodule. The examiner then gives you the ultrasound results. And wow, this is a textbook example of a suspicious nodule. The size, being hypoechoic, having irregular margins, and especially those microcalcifications, they all scream malignancy. For instance, those microcalcifications often mean cymoma bodies, which is a classic finding in papillary thyroid cancer. That's why it gets classified as TRADS 5, which is as suspicious as it gets. But honestly, the most critical finding here is the suspicious lymph nodes. That tells you the cancer has likely spread, which is going to be a huge factor in our surgical plan. And then the examiner gives you the final piece of the puzzle from the fine needle aspiration. The cytology confirms it. Papillary thyroid cancer. Not just in the nodule, but in those lymph nodes too. So your clinical suspicion is now officially confirmed by pathology. The diagnosis is set in stone. Now it's time to figure out the definitive treatment. So, with a confirmed diagnosis of metastatic papillary thyroid cancer, the whole conversation now shifts to treatment. And in this case, the main treatment is going to be surgery. The examiner wants to know if you can pick the right operation. This is the big one, the money question. It's direct, and it needs a specific answer. This is where you really show your surgical decision-making chops. What is the standard of care for this exact patient? The candidate's response has to be precise. The definitive treatment for this patient is a total thyroidectomy with a therapeutic central neck dissection. That is the key. You can't just say thyroidectomy, because we know there's nodal metastasis. Removing those lymph nodes in the central part of the neck is absolutely mandatory. Forgetting the neck dissection is a huge mistake. That specific two-part answer is what gets you the top marks. But listen, a consultant's job doesn't stop when the patient leaves the OR. To really nail this station, you need to show the examiner you're thinking about the patient's entire journey, from adjuvant therapy all the way to long-term surveillance. This shows a whole other level of care and understanding. So when the examiner asks about post-op care, you just continue with your structured plan. You'll talk about the need for radioiodine therapy and long-term follow-up with thyroglobulin levels. But here's the kicker, the thing that will really make you shine. You think beyond just this one patient. Recommending genetic counseling and screening for her family members, that shows a holistic, consultant-level approach that they are looking for. Okay, let's hit pause on the role play for a second. We've just gone through a complete Viva station from beginning to end. Now let's really boil down the principles that are going to lead to success, not just in this scenario, but in any clinical Viva you face. So, to recap, first, always be structured. It's your safety net. Second, you have to spot and call out those red flags. Show the examiner you know what's important. Third, be decisive. Give a clear diagnosis and a clear management plan. Fourth, think bigger than the immediate problem. Think about post-op care and family screening. And last but not least, communicate with confidence. Knowing your stuff is one thing, but you have to be able to sell it. So there you have it. You've just walked through a masterclass on how to tackle the thyroid nodule. The principles we've covered: structure, spotting red flags, decisive planning, and confident communication. These are universal. You can take this framework and apply it to any surgical scenario you come across. You've got the tools to ace this station. The only question is, what are you going to master next?